imaging of the musculoskeletal complications associated with immune deficient disorders in pediatrics. Thank you.
I'll share the presentation. بس كنت عايز اتاكد ان الكرسي موجود. Okay. بسم الله الرحمن الرحيم. Good morning, dear chairpersons. بسم الله الرحمن الرحيم. Good morning, dear chairpersons, professors, and dear colleagues. It's my pleasure today to share my brief talk about imaging of musculoskeletal complications associated with immune deficiency disorders in pediatrics. Immune deficient pediatrics MSK complications mainly are divided into three main categories: the bone complications, namely the osteomyelitis, the joint complications, the septic arthritis, and lastly the muscles and soft tissue include myositis, cellulitis, and soft tissue abscess. Regarding osteomyelitis, it represents the infection of the bone and the bone marrow. The infection is mainly hematogenous, however, direct spread after trauma is common. The bones affected includes the long bones, the femur, tibia, and humerus, and other bones like the bones of the pelvis and calcaneus are commonly to be affected. Regarding the pathogenesis of osteomyelitis, the hematogenous spread, usually the focus of infection lies in the metaphysis of the bone, then it spreads to the surrounding bone. The bone infection at first causes bone ischemia. Lately, it causes bone necrosis in the form which we call sequestrum. In the initial phase, there is also periosteal elevation and subperiosteal collection or abscess. Lately, in the disease process or in the chronic osteomyelitis, new bone formation is seen to be developed called involucular, and in some cases there are openings in the cortex which is destructed. It's called cloaca or sinus opening to drain the pus. Regarding the imaging findings in osteomyelitis, the ultrasound as a bedside test is very crucial in the first days before the onset of radiographic findings. The very pathognomonic sign in ultrasound examination is the periosteal elevation and the subperiosteal collection, which may be anechoic, meaning fluid, or echogenic, meaning pus collection. Also, we can see in ultrasound edema in the surrounding soft tissue. In this radiograph, corresponding to time to this ultrasound, the bone is quietly appearing to be normal. However, we can detect soft tissue around, shadow around the bone. Here is another case of a 2-year-old with humeral osteomyelitis. As we can see here, subperiosteal fluid collection which is pathognomonic for osteomyelitis here in these cases, and there is effusion in the nearby elbow joint. As regards conventional radiographs, the earliest sign are not present in the bone itself, but in the surrounding soft tissue. As we said before, there is soft tissue shadow around the affected bone, and there is, as we compare to the normal other side, there is blurring and loss of the fat planes in this area. Also, there is another finding which appears to be early in the radiograph, which is in comparison to the other side, there is a little bit osteopenia on the affected side. This happens when at least 40% of bone mineral density is lost. Afterwards, in the disease process, there are osteolytic changes in the form of, here as you can see in this case, osteolytic lesions with cortical destruction, periosteal thickening and elevation, and of course there is surrounding soft tissue shadow. There is another case in the metatarsal bone, the cortical destruction, the osteolytic lesion, the soft tissue shadow. In this case, the osteolytic lesion is seen in the metaphysis, and the growth plate acts as a barrier in some cases or most of the cases to be spread, for the infection to spread to the epiphysis. Lately, in the disease process or in the process of chronic osteomyelitis, there are the characteristic signs, the death or the necrosis of the central bone, which is called sequestrum, and the newly bone formation, the involucrum, and we can see here the sinus opening or the cloaca pathognomonic for the chronic osteomyelitis. MRI imaging is very crucial in osteomyelitis as it can detect early signs as far as 1 or 2 days after the symptoms. The main findings are the bone edema in the marrow, the bone marrow, which appear to be hypo-intense in the T1, hyper-intense in STAIR and T2 images, and post-contrast enhancement in the affected bone marrow, and periosteal thickening and enhancement of the surrounding soft tissue. And there is, in this case, enhancement and thickening of the nearby synovium of the joint, denoting reactive synovitis or true spread of infection to the joint, meaning septic arthritis. The broadest abscess is a term that is referring to localized form of osteomyelitis or subacute osteomyelitis. It has got rather a very characteristic shape. It's rather well-defined osteolytic lesion surrounded by dense sclerosis, and the other manifestations of infection, which is the soft tissue shadow and the very pathognomonic sign in radiographs, the blurring or the loss of the fat planes. In MRI, broadest abscess is commonly to be present in the metaphysis. As we said before, it's a localized form, well-defined. It can be surrounded by sclerosis in radiographs. Here in MRI, there is a post-contrast marginal infection characteristic of the abscess. As we said before, the growth plate in the infancy and the early childhood period acts as a barrier for spread of infection to the epiphysis from the metaphysis. However, broadest abscess is an exception. It can cross this growth plate. Nuclear medicine or bone scanning has got a role if MRI is not present, as it also detect early findings. Findings are sensitive, very sensitive, but it's not specific for osteomyelitis. There are increased uptake of the isotope scan or radioactive material in the blood pool and the bone delayed images. Another category of complications is the septic arthritis, and septic arthritis is infection of the joint cavity either from hematogenous spread or direct extension from the surrounding infected bone. In this diagram, I'd like to share with you the blood supply of the bone. In the neonatal period and the early infancy, the blood supply enters the bone at the metaphyseal region, and it directly spreads into the cartilaginous epiphysis. So the epiphysis shares the blood supply with the metaphysis. What does it mean? It means that infection reaches the metaphysis, could easily reach the epiphysis and hence to the joint cavity. So septic arthritis is very common in the neonatal period and early infancy. In the late infancy and childhood period, after the growth plate is present, it acts, as we said, as a barrier for the blood vessels to breach into the epiphysis, and the epiphysis has got its own blood supply. So spread of infection directly from the metaphysis is uncommon. However, as we said before, broadest abscess can cross. In the adulthood phase, after closure of the growth plate, again, the blood vessels can reach into the epiphysis and septic arthritis is more common. So in septic arthritis, it's difficult to establish a differential diagnosis between septic arthritis and transient synovitis due to the similar clinical manifestations. In this issue, in the literature, some authors published 4 parameters in case of septic arthritis of the hip to accurately diagnose septic arthritis. They relied on fever more than 38.5 degrees, ESR more than 40, YBC counts more than 12,000, and in this case, non-weight-bearing status. So the current gold standard is the identification of a microorganism in the joint fluid or in blood culture, in addition to the clinical and radiological findings which are compatible with bacterial arthritis. What about the imaging of septic arthritis? Ultrasound as a bedside test. Usually it's the first line of investigation. The very pathognomonic sign is the periosteal elevation and underlying fluid collection. This is very, very pathognomonic for the presence of underlying osteomyelitis. Of course, there is soft tissue edema in the surrounding soft tissue and increased vascularity. Again, I want to mention that ultrasound can detect early in the disease process small effusions as 1 to 2 milliliters, but it cannot distinguish between infected and non-infected effusion. So ultrasound is not specific for diagnosis of septic arthritis. Another point is that if we did not find joint effusion, this negative sign could surely exclude the presence of septic arthritis. Another case here, 4-year-old child with septic arthritis of the hip, the same finding, periosteal elevation and subperiosteal collection, and there is another case with effusion in the nearby elbow joint. What about radiography in septic arthritis? It may be normal in the early stage of the disease. However, the earliest finding is that, as we see in this case, there is relatively a soft tissue shadow, which is referring to distension of the joint cavity. There may be widening of the joint space, and there may be osteopenia of the bones of the joint due to increased vascularity and hyperemia. Later on in the disease process of septic arthritis, there is loss of the cartilage, subchondral bone destruction, as we see here, loss of the joint cavity, deformity, and ankylosing may occur. In MRI, it's very sensitive and specific to the findings early in the disease process. As we see here, we can see marrow edema at the opposing surfaces of the subchondral bones. There is, at the initial phase, widening of the joint space due to effusion, and lately it is narrowed due to a worsening of the disease process. There is enhancement in the surrounding soft tissue, and there may be enhancement at the synovium, denoting the synovitis of the disease process. In this case, a late case, we see here the deformity and the destruction of the cartilage and the enhancement around the joint. Another term is the infectious myositis, formerly was called pyomyositis. Infectious myositis can affect any muscle, and there is predilection for the large muscles of the pelvis, namely the psoas muscle, and the lower extremity in association with osteomyelitis and septic arthritis. In immune deficiency patients, intravenous drug use with unsterile needles, repeated muscle trauma, and prolonged immobility has been implicated as a cause of rhabdomyolysis and increased susceptibility to muscle infection. Ultrasound can easily detect pyomyositis if the muscles are superficial. The muscle is seen to be swollen. It could be hyperechoic or anechoic due to necrosis and cavitation. There is increased vascularity, and in MRI there is soft tissue shadow at the affected muscle region. There is contrast enhancement of the muscle, and there is, in this case, marginal enhancement denoting abscess formation. Regarding cellulitis and soft tissue abscess, cellulitis is an acute inflammatory process of the skin and the subcutaneous tissue, and can often progress to involve underlying deeper structures. Of course, cellulitis is a clinical diagnosis. However, we may need ultrasound to detect any underlying superficial pathology. In this case, compared to a normal skin, there is increased thickness and echogenicity of the skin and subcutaneous tissue, referring to edema of cellulitis. And in this case, after ultrasound was done, it revealed the cellulitis and underlying subperiosteal elevation and subperiosteal collection, denoting that there was osteomyelitis as a leading cause, and the MRI proved the presence of osteomyelitis. Cellulitis could proceed into abscess formation, which appears as a cavitation with internal different echogenicities and echoes. So my take-off messages today that imaging evaluation is a crucial component of the diagnostic workup of pediatric musculoskeletal infections. Conventional radiographs continue to be the first line of imaging modality for evaluating pediatric patients with musculoskeletal infections, particularly earlier in the disease course. Ultrasound is fast, non-invasive, and radiation-free, is ideal for evaluating superficial soft tissue infections and septic arthritis. In addition, ultrasound-guided joint aspiration can both facilitate diagnosis and provide symptomatic relief. MR imaging, due to its superior sensitivity and specificity, is the current gold standard to diagnose and localize sites of infection, in particular acute osteomyelitis and infectious myositis, and to identify associated complications. Thank you for attention. Any questions?
Thank you, Dr. Noha, for this great presentation, very informative and very presented الحقيقة.